Thanks very much for the opportunity to talk about the future of cardiogenic shock management. I think one of the most important advances that we've noticed over the past few years is improved definitions for cardiogenic shock. We've seen the recent publication of the SCAI stages consensus statement, which identified a platform for gauging shock severity using multiple hemodynamic, metabolic, and demographic variables. More recently, we've seen that there have been several publications looking at validating the use of these SCAI stages, and the Gensler analysis shown here at the bottom shows a direct correlation between SCAI stages and observed in-hospital mortality from the Mayo experience. And on the right, you can see here the European experience from Schrager and Westerman, showing again an association between in-hospital mortality as well as 30-day mortality and SCAI stages. The question I still think remains, though, is when we define shock severity is what do we do next? We've had a lot of discussion over the years about all of the various technologies for managing cardiogenic shock, including drug therapies, device therapies ranging from balloon pump all the way to VA ECMO. This recent summary from Saxena and Kern in Circ Heart Failure 2020 very nicely defines the field by showing all of the technologies that we have available. But one of the things that's missing in the field is the idea of exit strategies. How do we figure out who exactly is going to gain benefit from these technologies? And are there scoring systems that are specifically designed for acute mechanical support use in cardiogenic shock? And more specifically, identifying patients where it may be futile to subject them to some of these mechanical support approaches. Now, over the years, we've also gained better insight into the hemodynamics of cardiogenic shock. This used to be an area where we focused primarily on cardiac output and mean arterial pressure. But now what we're learning is that actually venous congestion and RV involvement is not only common, but actually is associated with increasing severity of cardiogenic shock. This analysis from the Cardiogenic Shock Working Group looked at biventricular congestion as one of the most common factors that we see in patients with cardiogenic shock, and also showed that with increasing SCAI stage severity, there's an increasing burden of biventricular congestion as well. The reason why this becomes important is that the use of the PA catheter, which has been heavily debated over years, I think is one that now we're beginning to see why the PA catheter starts to make a difference. We are seeing from the Shock Working Group registry that, again, for patients who are in SCAI stage D cardiogenic shock, actually this is where the PA catheter is associated with reduced mortality. Now in SCAI stage C shock, if you're a heart failure patient, there's still that association with reduced in-hospital mortality. But actually, if you're an MI patient with SCAI stage C shock, the PA catheter may not be as useful. So I think the question is developing algorithms for selective and appropriate use of PA catheters in cardiogenic shock. But ultimately, if we were to generate a randomized controlled trial, would you randomize a shock patient to PA catheter or no PA catheter? And I think that's really where we have a lot of challenge in the field. And so we as operators have to say we're willing to randomize patients to a PA catheter or no PA catheter. And this is where I think we are challenged in terms of advancing the space with randomized controlled trials. Now, we do know that hemodynamic guidance is central to any cardiogenic shock algorithm. This requires an in-depth knowledge about invasive hemodynamics, but also about the various technologies that you're going to be applying for a patient who has biventricular RV dominant or LV dominant cardiogenic shock. Now, I think one of the most important aspects of cardiogenic shock is the development of a randomized controlled trial. We've seen over the past few decades that there have been multiple attempts at randomized controlled trials, and these have been negative, going all the way back to the original shock trial in 1999. And since then, the IMPRESS trial, as well as IABP Shock 2, are all negative RCTs, which don't really show significant changes in terms of percent survival, no matter what technology is being studied. But we do see that with prospective registries employing hemodynamically driven algorithms, there is the promise of improved survival in cardiogenic shock. Now, the recent RECOVER 3 analysis looked at pre-PMA versus post-PMA analysis, basically showing that after implementation of best practices, we are seeing that there is actually in real-world data a reduction in in-hospital mortality. But the RCT is still required, and this is where RECOVER 4 is under development. Now, this trial will implement the best practices such as early support, pre-PCI support, hemodynamic guidance, an escalation strategy, and importantly, vascular safety for use of mechanical support in cardiogenic shock. And this RECOVER 4 RCT is going to be a critically important landmark study that's in development now. But one of the things that I think is really important, we talked about the importance of biventricular congestion, is that actually there's substantial heterogeneity in mechanical support device use for cardiogenic shock. And this actually is an analysis from the Cardiogenic Shock Working Group, again, looking at various SCAI stages and the use of devices within each stage. And what you can see is that as you start to go from C to D to E, we're actually implementing more and more biventricular support by the time we get to a SCAI stage E patient. And I think this sort of insight is really important to developing that RECOVER 4 trial, because it provides us with some understanding of how we're using the devices and why we may be using these devices. But to advance the field, ultimately, we have to randomize patients in cardiogenic shock. So we should ask ourselves, if we had a STEMI patient coming in with SCAI stage D cardiogenic shock who's referred for primary PCI, would you be willing to put that patient on drug therapy alone and randomize them to balloon pump or randomize them to Impella before PCI? The other aspect of this is, would you be willing to avoid crossover? And I think this is the real challenge in terms of designing the RCTs, but also implementing them, because if we do not randomize, we will not advance patient care. Now, there are a number of ongoing trials in mechanical support. This was a recent summary put together by Evan Whitehead, who basically showed that a lot of the trials that are active right now are actually implementing ECMO. And you can see that there are about 5 or 6 trials that really focus on the use of ECMO in cardiogenic shock. Now, I think this is critically important because we are seeing a significant increase in the use of ECMO for cardiogenic shock. There's been an 11-fold increase in the use of VA ECMO for AMI cardiogenic shock over the past 10 years. This is still associated with an in-hospital mortality between 40 to 60%, depending on the study you look at. And what we're also seeing is that there's increased concomitant PCI or additional mechanical support with VA ECMO. And the fact that we're seeing a substantial use of same-day VA ECMO plus other MCS is really important, because it suggests that ECMO alone is not going to solve the cardiogenic shock equation. And in fact, additional mechanical support is required to stabilize a patient on VA ECMO. Now, this, of course, is important because it leads to some of the complications associated with ECMO. And I think that a lot of the ECMO outcomes are driven by these complications, such as vascular injury, stroke, acute kidney injury, LV distension, and aortic root or LV thrombosis. So we as interventionalists have to get better at understanding ECMO, as also better and how we implement ECMO in the cath lab. And I think this is really some sobering analysis coming out in 2020, showing that there's actually an increasing trend upward of vascular complications or other complications with the use of ECMO. And I think this again really suggests that we need to get better at ECMO, we need to understand it, and we need to improve its innovation of how we implement ECMO in the cath lab. Now, we've all seen data showing that Impella is associated with better survival than VA ECMO. This hasn't been studied in a randomized controlled trial, but some of those studies are underway. But in reality, when you look at VA ECMO with Impella activation, this is actually an area where there's substantial risk for complications, both vascular complications and other complications. And here at the CVI meeting, we'll be talking about some of the new approaches to try to reduce some of this risk in patients with VA ECMO requiring Impella support, who also require concomitant PCI. And this is highlighted by a recent analysis by Mohit Pahuja, showing that with increasing French size, going from balloon pump to PVAD to ECMO, there's an increased risk of acute limb ischemia, and that untreated acute limb ischemia is also associated with 100% in-hospital mortality. So some of these vascular protection strategies you're going to learn about at this meeting are really important, including the post-closure technique, the single-access PCI, as well as distal limb perfusion techniques. Now, another area that's advancing in cardiogenic shock management is the use of Smart Assist. This is where the Impella console is now beginning to provide us with important information about LV hemodynamics, as well as systemic blood pressure. This is an Impella configuration showing uncoupling of the LV tracing from the systemic aortic pressure tracing. And I think these types of learnings are going to be very important for how we manage going forward. The way to gain knowledge and skill outside of clinical fellowship is to engage with some of the educational platforms. This is the CAMP PCI platform that was just developed over the past year, where you can actually go into the portal and listen to lectures and see cases that implement some of these best practices for cardiogenic. This is the specific lecture around Impella, which I think is very important for clinicians to understand how we can manage patients with Impella using hemodynamic guidance. So with that, thanks very much for your attention.